Welcome, everyone, and thank you for joining us for the first UCLA Health Dr. Martin Luther King Jr. Health Symposium. I'm Dr. Medell Briggs-Melanson, Interim Chief of Health Equity, Diversity, and Inclusion for the UCLA Hospital and Clinic System. Thank you for joining us today. As we wait for more of our guests to enter the Zoom meeting, I'm going to go over a few programming notes and let you know what you can expect during tonight's section. All of our program attendees have been placed on mute. You will be able to ask questions via the Q&A chat box. You can also like a question by clicking the thumbs up icon, just like Facebook. Questions that receive the highest number of likes will be asked today with our panelists. Please include your name if you would like to ask your question directly yourself, or you can also put your question anonymously and I will read it for you. The Q&A section will start immediately following the panel. Please also be aware that this program will be recorded and the video will be available soon. During the next 90 minutes, you'll hear from 5 amazing panelists from across the UCLA family who will discuss some of the most pressing topics that are currently impacting the Black community and other communities of color. They include the legacy of racism and mistreatment in healthcare, COVID-19, and overall health and wellness. All right. It looks as if we have enough people who have logged in, so let's go ahead and officially start the program. Again, my name is Dr. Medell Briggs-Melanson, and I am the Interim Chief of Health Equity, Diversity, and Inclusion for the UCLA Hospital System, as well as an Associate Professor of Emergency Medicine at the David Geffen School of Medicine. I want to welcome you to the first annual Dr. Martin Luther King Jr. Health Symposium. In celebration of Dr. King, this new annual symposium will focus on highlighting people, issues, and efforts that are committed to advancing justice in healthcare. This year's theme is Confidence in Crisis, Strengthening Medical Trust within the Black Community during the COVID-19 pandemic. The year 2020 and the first weeks of 2021 have highlighted the quadruple pandemic that hit our country: COVID-19, racial injustice, economic hardship, and political divide. While COVID has impacted everyone in this country and throughout the world, it has greatly impacted people of color and people who live in highly under-resourced communities. Let's talk about the stats. To date, Blacks and Latinos are more likely to be infected by the virus and be hospitalized than their white counterparts. And Blacks and Latinos are 2 to 3 times more likely to die from COVID here in Los Angeles County than whites respectively. Lastly, people who live in low-income communities are 4 times as likely to die from COVID than people who live in wealthy neighborhoods. COVID-19 has clearly exposed both the health and social inequities that have existed in this country due to system racism and other social structural factors for generations. But we now have a vaccine that has been proven to be highly effective against COVID. However, there are still concerns within the Black community in particular about taking the vaccine. But what are the causes for this distrust? Is there intergenerational trauma for medical racism? Is it the current political turmoil, skepticism of science? Well, today we're going to discuss all those topics and a whole lot more as we dive into the legacy of medical racism and mistreatment of the Black community and its impact on us today. We will also discuss the COVID pandemic, the COVID vaccine, and what we can do to build greater trust within the community. Now is our time to heal, and now is our time to thrive. So before we get started, as a land-grant institution, UCLA Health acknowledges our presence on the traditional, ancestral, and unceded territory of the Gabrielino Tongva peoples. We pay respect to the ancestors, elders, and relatives, past, present, and emerging. All right, let's jump right on in. I would like to introduce our incredible panel that we have tonight. First, we have Dr. Omai Garner. Dr. Omai Garner is an associate clinical professor at the David Geffen School of Medicine and director of clinical microbiology for the UCLA Health System. He received his PhD from UC San Diego in biomedical sciences. He was a postdoctoral clinical microbiology CPEP fellow in the Department of Pathology at UCLA and he is a former McNair Scholar. Dr. Garner is a board certified by the American Board of Medical Microbiology, and his research focuses on novel point of care devices for infectious disease diagnosis in the developing world. Dr. Garner also serves as the chairman of the board for the Social Justice Learning Institute in Inglewood, California. And by the way, Dr. Garner and his team, they have been at the core of all of our COVID pandemic efforts for the past 10 months. Next on our panel is Dr. Naina Harara. Dr. Harara is a professor in residence at the David Geffen School of Medicine and the Fielding School of Public Health at UCLA. She also has a faculty appointment at the Charles R. Drew University of Medicine and Science, where she serves as the faculty leader for the university's Center for AIDS Research, Education, and Services, otherwise known as Drew Cares. Dr. Harara's research involves understanding trends in HIV and other sexually transmitted infections and developing effective, culturally relevant interventions for prevention care and treatment with a specific focus on high-risk African-American men, at-risk African-American and Latino women, older adults, transgender women, and people leaving incarceration. She currently leads numerous research projects, including being a co-lead for 2 multi-site NIH-funded studies related to HIV and incarceration. Our next wonderful panelist is Ms. Anna, otherwise known as Aziza Lucas Wright. Ms. Lucas Wright is the Vice Chair of the Department of Preventive and Social Medicine, Co-Chair of the Division of Community Engagement, and Co-Chair of the Academic Senate's Clinical and Community Programs within the College of Medicine at Charles R. Drew University of Medicine and Science. Ms. Lucas Wright is also a community partner for the UCLA Clinical and Translational Science Institute, otherwise known as CTSI, at both UCLA and CDU. She is also the lead for the Coronavirus Prevention Network's community outreach team at CDU, a member of the Stop COVID-19 and SIL project at UCLA, and lead for the faith-based community-based organizations and academic partnerships. She is also a community reviewer for the COVID-19 Equity Evidence Academy Initiative in North Carolina. Dr. Vicki Mays is our next panelist. Dr. Vicki Mays is a distinguished professor in the Department of Psychology in the College of Letters and Sciences and in the Department of Health Services in the Fielding School of Public Health. Dr. Mays is also the director of the UCLA Bright Center for Science, Research, and Policy that focuses on the innovative use of research, science, and policy development to help eliminate disparities in physical and mental health for communities that are traditionally underserved by academic research. Dr. Mays' research primarily focuses on the mental and physical health disparities affecting racial and ethnic minority populations. She also serves as the PI of the California Quality of Life Survey. Dr. Mays and her colleagues in the Luskin School recently developed a new predictive equity model for the COVID-19 vaccine rollout. In addition to all of her other roles, she also serves as the special advisor to UCLA Chancellor Gene Block on Black Life. And last but not least is Dr. Keith Norris. Dr. Norris is an internationally recognized clinician, scientist, and health policy leader who has made major contributions to diversity, equity, and inclusion while addressing disparities in contemporary society. His research interests focus on hypertension and chronic kidney disease in historically disadvantaged and oppressed populations. Other research areas include the role of health inequities that lead to health disparities and also promoting community academic partnerships to address health inequities and issues such as COVID-19. He is currently working very closely with Dr. Arlene Brown at UCLA at an NIH-funded project called the COVID-19 California Alliance, otherwise known as Stop COVID-19 CA, whose goal is to improve COVID-19 knowledge and increase participation of all Californians, including underrepresented populations in prevention, vaccine, and therapeutic trials, as well as to improve the uptake of approved vaccines. Dr. Norris has co-authored nearly 450, yes, 450 articles in peer-reviewed journals and book chapters. He also serves as the editor-in-chief emeritus of the International Journal Ethnicity and Disease. It is my absolute honor to sit on this panel with such esteemed scholars and change agents. Thank you all for being with us tonight. So we're going to go ahead and jump right on in, and especially when talking about and thinking of the legacy of medical racism. So my first question is going to be directed to Dr. Harara. Dr. Harara, we have heard through our families, our peers, our colleagues, stories of medical mistreatment of the Black community. From an expert's perspective, can you share with us some of these transgressions, as well as how has this impacted the relationship that Blacks and African Americans have had with the medical community, especially during the current COVID pandemic?
Yeah, I'm going to address that question and do it from what I think is a somewhat different perspective. The last several years have brought increased recognition to these stories, to the ways in which African Americans have been mistreated within the scientific endeavor. More and more members of the general public and those engaged in healthcare and research have learned the details of the National Health Service study of syphilis at Tuskegee and of the tremendous contribution that the cells of Henrietta Lacks brought to science, but without the permission of her or her family. But I want to tell a key part of these stories and other stories where Black individuals were engaged in unethical research that is rarely told. And by that, I mean the systematic changes that the revelation of those nefarious research endeavors brought about. That story includes the fact that the ancestors of Henrietta Lacks now serve on the National Institutes of Health HeLa Genome Data Access Working Group. This is the body that determines whether or not researchers have access to the rich genetic information of those cells. That story also includes the fact that the revelation of the National Health Service study of syphilis at Tuskegee led to the 1974 National Research Act, which required the development of the National Commission for the Protection of Human Research Subjects and the requirement for institutional review boards to review and approve nearly all research involving human subjects. And finally, the detailed requirements for voluntary informed consent of human subjects. It is because of these processes of consent that the people who take part in research studies are no longer just subjects experimented on, but true participants who take part of their own will and are therefore contributing in a voluntary and active way to the potential for science to benefit society. But of course, as you stated in your question, African Americans' fears around medical treatments and vaccines are not limited to our experiences with research. We've also experienced poor treatment within the medical system. But when I look at both the recent and not so recent history of how Black people are sometimes treated in healthcare, the dominant through line is one of undertreatment and neglect, rather than the type of toxic or otherwise nefarious treatment that some people might fear would be part of a vaccine shot. Unfortunately, we've seen these stories of neglect even in the COVID-19 pandemic. There have been multiple news stories of symptomatic individuals who are turned away from emergency rooms only to later die at home. We've seen it in studies documenting undertreated pain, ignored concerns of pregnant patients leading to maternal mortality, and the lower frequency of referrals for aggressive procedures for individuals with heart disease and other conditions when comparing Black patients to white patients with similar disease profiles. But it's for this reason that my biggest concern is not about our populations being given something dangerous or toxic. There are processes well in place to prevent that. And the sacrifice of the participants in some of those studies is part of why those processes are there. My biggest concern is that somehow we will not be prioritized as we should, that will be overlooked or potentially left behind as the already confusing and sometimes unorganized vaccine rollout moves forward. I'm concerned about our overrepresentation in the essential workforce and in the criminal justice system, especially given that the largest outbreaks of COVID-19 throughout this pandemic have been in our prisons and jails. But even despite that, people in prisons, jails, and detention facilities have yet to be prioritized for vaccination in most states. It is disappointing that the tremendous investment on Operation Warp Speed to develop the COVID vaccines was not accompanied by a stronger investment in educating our communities from the beginning about the development and approval process, the novel vaccine platforms being explored, and the people involved in the development and testing of the vaccine, including the many Black participants in the clinical trials. Instead, Black educators and providers, such as those on this panel, and Black institutions, such as the 4 historically Black medical schools, have stepped in to fill this gap. So I would argue that we need to continue to advocate that we have a place near the front of the line, because we are overdue this place. So while we deal with the very real and reasonable fears of members of our community about this vaccine, we cannot lose sight of the goal that as many of us, as soon as possible, are educated and receive the opportunity to be well protected against COVID-19 disease.
Well, thank you so much for that. And so many of those different points that you mentioned were key. It's not just about the past research or unethical experimentation. It's about the contemporary issues, what has occurred in terms of treatment, what has occurred in terms of is there education or not education? And those are all the factors that feed into this level of distrust that we continue to have within the Black community and that we have to address. And so I want to sort of shift that to our next panelist. And this question is actually for Dr. Mays. So thinking about these different aspects, thinking about the history, thinking about the legacy, but also thinking about some of our current challenges now, especially with COVID. Can you tell us, Dr. Mays, in particular, that COVID-19, we tend to think of it as just solely a medical problem, and especially when we're considering vaccines, but COVID has impacted the Black community in many other ways as well. Can you share with us how COVID has caused additional stresses and strains on the Black community? And I believe you have some slides that I'll
I
show
do.
right now.
Thank you. And first, let me start by thanking everybody for coming because you've had a full day already. And so when I talk about stresses and strain, I have a feeling I'm talking to the right set of people. Next slide. So part of what I really want to talk about is this notion of social determinants as one of the risk factors. Because what you've heard throughout, much of the information that's gone out is that what puts you at risk is predominantly having a pre-existing condition. Next slide. Some of you are very familiar with social determinants, some of you may not. It's the federal government, for example, uses social determinants to measure our health. And social determinants are part of what makes, particularly in the minority community, many of us at greater risk. So earlier we talked about, Blacks and Latinos being 2 to 3 times more likely to be infected and also to die from this disease. Part of that doesn't have to do with that we do not take care of our health, but it has to do with the ways in which structural racism makes us more vulnerable. Next slide. So this is a study that was done by the federal government, particularly the Census Bureau. And what they did was every week they followed a group of people and they asked them questions about, what their status was in terms of COVID-19, as well as questions about these social determinants. The 3 top things that we can see that were related to social determinants of health relative to being at risk for getting infected were these, what we're calling the threats to survival. It was stresses and strains. So people, for example, who had income insecurity, people who had food insecurity, and people who had housing insecurity. Those were 3 of the top things that actually were put people at risk in terms of developing COVID. So what you saw is that in relationship to coming into contact with this infection, it's not just whether or not you are physically healthy, it's also the ways in which the very things that COVID-19 is doing, which is to put our economic system in great disarray, those very things were also making people more vulnerable. And I don't want to get really complex here, but one of the things to know is that when you experience stress, Stress then becomes a physiological process that begins, for example, to have you in an overload almost in terms of the ways in which you are coping with, kind of everyday stresses and strains. Those things tend to wear you down. We often talk about that concept of, how much the body can be worn. And so in this study, what you can see is that when people are anxious about whether food is available, and for me, the most heartbreaking thing in this study, looking at the data, was that African Americans were significantly higher than all others in saying that during this time of COVID, they did not have enough to eat. So if you want to think about things you can do, there are a lot of things that you can do, even in terms of volunteering. And what this also tells us, I'm a policy person, is that policies are important. Next slide. So what I came up with Professor Paul Ung and his team over in Luskin was to think about what were the ways in which these social determinants put people at a greater vulnerability for potentially, if they come into contact with the virus, to end up becoming infected. And again, what we're able to see is that important issues here were, yes, those pre-existing health conditions are important, but barriers to accessing services. And I'm not just talking about health services in general, such as language issues, not having good educational opportunities. The other thing is built environment, and this should make a sense to all. Some of us have a lot of open space. Some of us live in neighborhoods where we can barely walk outside. And then the social vulnerability index. We often talk about this as kind of like social risk, your ability to be able to do things. If people want to see more about this model, they can feel free to go to our website. Next. So this is the big take-home message that I want people to be thinking about. Right now, we're very focused, as we should be, on the physical aspects of COVID-19. But please listen to know that on the tail of COVID-19, there is a syndemic. And those of us, and I know Nina would know this, those of us in HIV often talked about the syndemic that followed at HIV. Same thing for COVID-19. And that is, there is going to be a mental health syndemic that is going to occur. And so what we're seeing because of COVID-19 is an increase in mental health problems. So that means we need to think now about how to set up services. We need to think now about the things that people are experiencing that are causing them to feel the anxiety, depression, et cetera, that they are experiencing. The next thing is there's an increase in suicide, and particularly in the Black community. It's young men 5 to 12 are beginning to have an increase in suicides. And finally, we've seen several studies that have shown us we're home, we're drinking just a little bit more, we're having a little more Zoom happy hours. Well, some people are having those happy hours during work hours all day long and into the evening. So while I, really say that we should have some breaks and, have a Zoom happy hour, we do have a real increase in substance abuse. So this is the next thing we need to start thinking about, which means setting up, for example, substance abuse treatment on demand. It means increasing our suicide prevention efforts. And it means having much more culturally competent, not just mental health services, but interventions to increase emotional well-being. I think I'll stop here.
Wow, that was exactly what we need to hear, and very powerful, Dr. Mays. So putting that all together, yes, as you mentioned, there's so many other factors that impact our health. But in particular, we need to start thinking about the future. We need to start planning for this syndemic. We need to start preparing to address what we already know will happen in terms of mental health and overall well-being, and hopefully try to address it even right now and stop this pandemic as soon as we can, because if not, we know this will continue on, and hopefully we can at least prevent the worsening of mental health and suicides and the substance abuse in which we have definitely been seeing it. As an emergency physician, I can tell you that it seems that we have seen a lot more patients coming in complaining of various different both behavioral health and other mental health conditions. And it's heartbreaking, and it's definitely heartbreaking. And we're all underneath stresses, and we have to do what we can to try to stop it as soon as possible. And so that actually transitions us into what can we do to stop the pandemic so that we can also start creating more of these preventative programs to both support our overall health as well as our mental health. And so I want to turn this to Dr. Garner as well. And Dr. Garner, we finally have a vaccine against COVID, right? But there have been so many questions that so many of us have heard about this vaccine because it's a little bit different than what we may have been familiar with in the past. Now, you're an expert microbiologist as well as immunologist. Can you tell us what is the COVID mRNA vaccine? How does it work? And then also, where are the origins of this vaccine and how was it developed?
Yeah, I would be more than happy to. I'm honored to sit on this panel and to share the information that I have. And so in talking about the mRNA vaccine, I really want to start with what's a vaccine, right? And so a vaccine is based around this concept called protective immunity. And the idea of protective immunity is that when you encounter a virus, when you encounter a bacteria, your immune system fights it off. And then when it's done fighting it off, it actually remembers that it fought that particular pathogen. It creates antibodies that move throughout your system. And these antibodies are able to, if you encounter that same bacteria or virus again, fight it off so fast you don't experience any symptoms. And so this is really this concept of protective immunity, right? You get sick once, you can't get sick again with that same thing. Now, that's a great thing that our immune system does. The challenge is you have to get sick the first time. And what we're learning through this pandemic is already, unfortunately, 300,000 people have succumbed to this virus in their first interaction. So a vaccine really tries to get around this notion. A vaccine asks the question, can we build protective immunity without actually being exposed to the disease? And so there are a number of ways to do that. And I really want to focus in on how the mRNA vaccine actually does this. So one way to create a vaccine is to expose a person to just a small portion of that virus, not the whole virus, just a small portion that'll create that protective immunity. Now, this involves a lot of medical research, right? You have to pick the right piece of the virus to expose somebody to so that they can create those antibodies and be protected. So the research has shown with COVID-19 that the spike protein, and I'm sure you've heard about this, the spike protein. This is a protein that's on the outside of the virus that actually helps the virus infect cells and cause disease. If you just expose a person to that spike protein alone, not the whole virus, just that spike protein, the body will make a response, an antibody response to that, and create this level of protective immunity. That's fantastic. And all of the vaccine products are going to be based on this exposure to the spike protein. The challenge is making that spike protein is very difficult to be able to inject it and produce the response that you want. So let's get into then what the mRNA vaccine is. A virus is composed of two parts. It has the proteins along the outside that actually mediate disease. And then it has this genetic code. This genetic code is called RNA. And this RNA is instructions for how to make the whole virus. So when a virus infects the cell, it releases these instructions and the cell then makes more virus. The mRNA vaccine takes advantage of this. It uses the mRNA code, the genetic instructions, just for the spike protein. So what happens in the mRNA vaccine is that's injected into the arm. The cells in that area of the arm, they pick up this small piece of genetic code, this small piece of instructions, and make the spike protein. So now you have the spike protein being expressed in this area. The immune system sees that, creates antibodies, and then makes this overall level of protective immunity. So it was a novel approach. It was really, this has been in the pipeline though for years. So we talk about it as novel, it's a new vaccine. It means it's newly approved. But the idea of an mRNA vaccine has actually been pursued for the last 10 years. And so over time, medical research has shown this is a way to make a vaccine that's effective, and you can measure that protective immunity response to show that you get antibody to that spike protein, but it's also a way to make it faster. The idea of this pandemic is we needed a cure, we needed a vaccine as quickly as possible. So it was the progression of that medical research that brought us this mRNA vaccine. And I'll emphasize a couple of questions just to handle straight out. It's only a small portion of the genetic instructions for the virus, about 10% of the overall virus. So when you get that mRNA vaccine, it can't make the entire virus. It can only make the spike protein. And so in that setting, you can feel confident it's not going to make the disease itself. And I will just end on, just like many of our successful novel medical interventions, it was a Black woman who was one of the more important scientists that was involved from the NIH, Dr. Corbett, who put some of the medical research together so that we could have this mRNA vaccine. So I think that I'll end there, and yeah, hopefully that was informative.
Yes, that was definitely informative, and we appreciate you ending it that way as well. And so now that we know a little bit more about the mRNA vaccine and how it works and how the body responds, I do want us to transition over to Dr. Norris. So Dr. Norris, you have conducted numerous clinical trials and have been responsible for helping to enroll people of color into the COVID trials that we have even right now. But a lot of people have had questions about what are these different trials all about? What are some of the new safeguards? And most importantly, what have these vaccine trials shown? Tell us more about the Pfizer Moderna COVID trials. And so I know you have some slides as well. And so we'll go ahead and share those. And Dr. Norris, can you answer some of those questions for us?
My pleasure. Next slide. So, as you said, what are clinical trials? What are some of the safeguards that have been put in place? And then what are some of the results of the Pfizer and Moderna COVID trials, particularly as it relates to Black and Indigenous people of color? And so we'll talk a little bit about that. Next slide. So a clinical trial is a systematic approach. It's a structured approach. We put together a formal system and then test if a clinical intervention works. And that clinical intervention could be a medication, such as an antibiotic, could be a vaccine, such as the COVID vaccine. It could be exercise. And we can do a clinical trial to see if exercise helps. We've shown that exercise helps to prevent prediabetes from going to diabetes. And so these are trials. And what they do is they look at new ways to either prevent, detect, control, or treat a disease condition. And with the vaccine, we're hoping to really prevent or to sort of control the infection per se. So that's not so bad. And the important thing that a trial does is to find out whether or not this new test or new treatment is safe and is it effective. So both safe and effective, those are the two key things there. And then we also, when we do trials, we also want to make sure that we have people from different ages, different races and ethnicities, different genders, to see how different people respond. And one thing people may have heard on the news, right now the COVID vaccines are not approved for children. So Pfizer's approved down to 16 years of age, and the Moderna vaccine down to 18 years of age. So those studies haven't been done yet. And so we don't really know how safe it is and how effective it is. Next. So how does the trial work? So first we have what's called the preclinical stage, which is where studies may be done in cells, such as we heard about the HeLa cell. They could be done in animals, in mice and rats, and sometimes even in primates, such as chimpanzees. And so there actually had been a lot of work already going on around coronaviruses. So because of that, a lot of information was already known, and they were able to quickly get to phase 1, where they first test to see whether or not it's safe and does it have any efficacy. And then it goes to phase 2. We now look at that in a larger group of people, and then phase 3. And typically this will have a few thousand people. And then that gets reviewed usually by the FDA. It goes out to market. And then they continue to do surveillance to see how effective this is, these interventions are, and how safe they are. And so we are at the FDA review phase. We've just passed the FDA review. It's a fast track for the FDA review. But one of the main things when people have asked about, well, how did this Operation Warp Speed happen, and how did it happen so fast and so quickly? Well, normally a company is not going to make any extra drug until they get FDA review approved, because they don't want to put money and make a whole lot of drug and find out it doesn't get approved and it sits there and they've spent a lot of money. But in this case, the government said, it's looking good early on, just go ahead and make millions and millions of doses. And if it doesn't work, don't worry, we're paying for it. So the difference here is all those millions of doses have already been started, and that's why things are moving along as quickly as they are. Next. Well, what are some of the safeguards? As Dr. Harawa mentioned, particularly following the Tuskegee syphilis study, there was a commission created, a Belmont report was created, and this is to safeguard all people participating in clinical research, but it was done in response to mistreatment of people of color. And the 3 key principles that underlie the conduct is to have respect for people, to make sure there's beneficence or benefit, and that there's justice. And so those are all looked at. They're looked at carefully. We have institutional review boards that look at those as well. Next. And the institutional review board has to approve every clinical trial. And it's made up of doctors, scientists, and people from the community. And then there's informed consent that is given to the participants, and they look at it, their family members can look at it before joining a study. And then large trials also have additional safeguards. So they may have an additional data safety monitoring board. And then if it's going to go to market, then it has to go through FDA approval, and there's another board that reviews it. So there are multiple layers of review and approval before these drugs come to market. Next. So what happens? Now it's at market, and what have we seen? So this is a little bit of data from the Moderna COVID vaccine trial. So at the top right, you see Dr. Fauci getting his vaccine, and at the bottom below it is, that's who Dr. Garner mentioned. That's Dr. Kizzy Corbett, who's one of the senior scientists working with Dr. Fauci and his team. And she did a lot of work on some of the mouse studies with the vaccine and the chimpanzee studies with the vaccine, and helped to create the vaccine that, as you see here, is 94% effective overall. So 94% effective. In the study, little over 20% of the participants were Hispanic, little over 10% were Black. In people of color was 97.5% effective, so that's really good. And if you remember, I said there can be 1 to 3,000 people in phase 3 of a study. This one had 37,000 people. And so with 37,000 people, you really get a good look at how effective it may be and how safe it may be. And also, not only was it effective, but that no individuals who got the Moderna vaccine ended up with severe COVID, right? So that's also important. So some people had, 5% or so had COVID, but they didn't have a severe case of COVID. And what we want to do is really prevent people from going to the hospital or from dying. So that's very important. Next. Similarly, the Pfizer vaccine, 95% overall, and it was 100% effective in Black persons and 94.5% effective in Latinx community. Now there was 9%, again, over 37,000 people, 9% were Black, 28% were Hispanic. Do I think it's going to be effective in every Black person who gets it? I don't, okay? But it was, so eventually somebody may get it, but it looks like it's working pretty well. That's what we want to know. But 95% is really great. The side effects are fairly similar for both of them. A lot of people get pain at the injection site. A lot of people maybe as sometimes in as few as 10%, as many as 60% may have headaches or weakness, muscle aches and chills, nausea. For those of us who are a little older people have fewer side effects. So that's important to note. But in general, the side effects tend to be mild and only last a couple days. For people who have a lot of allergies, then we want to be much more cautious. And so whenever you go to get your vaccine, they will have you wait for 15 minutes to make sure you're not developing any complications. Next. So in summary, the two vaccines that we have available are 95% effective. It's also good to know not all vaccines are that effective. There are vaccines around the country, around the world that are 50% effective and have other concerns or side effects with them that are limiting their use. Importantly, they prevent hospitalization and they prevent death. The side effects usually just last a couple of days, and it worked just as well in people of color. So I think the data looks very strong right now, and it's great to know that right now we do have an intervention that can have a very positive impact. And I think as you heard earlier, this is extremely important for communities of color because we are suffering so much more from the ravages of COVID-19. So I'm going to turn it back to Dr. Briggs-Malance. Thank you.
Thank you, Dr. Norris. And I want to really make sure that we reiterate a couple of points here. Number one, as you mentioned, this vaccine, all of the vaccines that are currently approved have gone through the same exact stages as any other medication, as any other vaccine that has ever been approved in this country. So I want to make sure that we're clear about that. So that's one point. And the second point is that the vaccines, both of them have been proven to be highly effective at fighting COVID and preventing hospitalization and death. And so as we are talking about that COVID causes both physical issues as well as mental health issues, socioeconomic issues, this is our chance that we can help to stop this. And so I just wanted to underscore those items there. So thank you so much again, Dr. Norris. So now that we're talking about, and we've gone through the process of the legacy of racism and mistreatment as well within the Black community, we've also discussed some of the social determinants that impact one's vulnerability, as well as the mental health effects. We talked about the mRNA vaccine, what it is, how it's not really new, and then also discuss the clinical trials and how effective these vaccines are. I now want to shift a little bit more towards the community and really think about, well, where do we go from now? So Ms. Lucas Wright, you are a prominent community health advocate. What have you been telling the community regarding the vaccine? And what are the ways that you think are most important in order to increase awareness and overall vaccine acceptance?
Thank you. So first of all, it really is important for the Black community to have access to the vaccine, because it is still true that when the country gets a cold, we get the flu. When the country breaks a fingernail, we have a finger amputated. So I've been very fortunate to work with a number of partners to develop across community milieus to develop community advisory boards that have representation from the African American, the Latinx, indigenous tribal nations, Pacific Island, ocean peoples, LGBTQ, and our super spreaders, our Gen Xers, so that alongside these multiple segments of the community, we've been able to create opportunities to have town halls. One example is that we created what was called the Sabbath Town Hall at the intersection of faith and wellness. Sabbath town halls that occurred probably right after worship service in these houses of worship for Black folk to hear from professionals that might trust that they might trust regarding the vaccine. So these opportunities provide a fairly a considerable amount of time to have questions answered and the perspective of community considered to shape the narrative and strengthen the narrative for those who are service providers and those who are the gators, those who are making decisions about allocation and resource distribution. One of these, I was reading some research literature earlier today that had a listing of all of these different types of research where African Americans participated in, and the percentage of African Americans participating in this vast array of research was somewhere around, the highest was like, I think about 12% at the most, all the way down to 1%. And the majority of the percentage was well under 5%. It was pretty egregious and pretty abysmal, I mean. And so when I see, though, that the numbers, the percentage of African Americans who have been participating in these clinical trials, vaccine clinical trials, while I'm not wild about the percentage, it is better. And I have a feeling that is because there have been so many town halls and so many convenings set up and established with people who look like the people that they are speaking with. So it's congruent convenings happen. So one answer to that is, when possible, if you are in the position to do it, either create bi-directional learning convenings that are, again, culturally congruent to mitigate medical mistrust and opportunities to voice fears and concerns. Do it often and aim them at other really good convenings that are already canned. If in fact you don't have the opportunity or the ability to do that, then just aim them at those really good ones that are already in the can, already you can already go into it and it's already streaming. You can always jump right into it. And it's also good for those of us who are service providers or who are considered, because of the kindness of community, considered leaders. Take a picture of yourself getting the vaccine. It goes a long way. And finally, I would say redirect folks from the social media platforms that proliferate miseducation and diseducation, and that just sends folk down the rabbit hole. And so I think that again, it's critical to have those that you are talking about at the table, telling you what they think, what hurts. And I have, after all of this time, listening to a variety of people over a good period of time, I think it still drills down to just two things. Number one, are you going to hurt me again? And number two, does it offer hope?
Wow, thank you for that. So number one, are you going to hurt me again? And number two, does it offer hope? And I hope that through this, we can help to deal with those fears that people may still have. And so thank you so much for your insight about the importance of information that is coming from credible sources, and also the importance of addressing people's concerns. And that's what we all hope to do tonight. And I want to just now go into some of those concerns. And we're almost there to the question and answer section. So you all go ahead and put in your questions and we will definitely try to answer as many of them as possible. If you see questions that are already there, just go ahead and upvote them. And those that are upvoted are going to be the ones you can answer live, but we'll still try to get to as many questions as possible. But we want to talk about some of the various different concerns that we have actually heard directly from our community. And we're going to move through these pretty quickly so that we can still get to all of the questions from the audience as well. And so one of the very first concerns that we hear very commonly, and I'm going to direct this to Dr. Garner, is will the mRNA vaccine change my DNA? Dr. Garner, what's your answer to that?
So the answer is no, the mRNA vaccine will not change your DNA, but it's a very good question because there are viruses that we know that can affect your DNA. And some of the long-term consequences of that are cancer. So things like the HPV virus causing cervical cancer or EBV causing a wide variety of cancers. And so just real quick, why the mRNA vaccine won't change your DNA. Your DNA, which are the genetic code or instructions for all of you, is set aside inside the cell in an area called the nucleus. The nucleus is actually a protected environment. When the mRNA vaccine gets inside the cell, remember to make that spike protein, it never goes anywhere near the nucleus. So because these two things are completely compartmentalized, plenty of research has shown both in experimental and even from a human perspective that there's no alteration to the DNA whatsoever, i.e. there's no cancer or long-term effects because of that.
Well, Dr. Garner, I think you almost answered the second most common question. Will the COVID vaccine cause me to have cancer, an autoimmune problem like lupus, or some other long-term problem? So it seems like you already answered that question in itself. Any other items that you would like to add or anyone else from the panel to this second question?
I would just say briefly, long-term complications from vaccines are exceptionally rare. And so in that setting, this vaccine product, remember, it makes the spike protein. While it feels different, it actually is very similar to other well-established vaccines that have been well studied and shown not to have any long-term problems.
Thank you. And if I can add one piece as well, we have actually tracked vaccines and what occurs long-term after vaccines for a while. And most of the time, if there is any adverse effect, it tends to occur normally 6 to 8 weeks following the vaccine administration. We know from the tens of thousands of patients that have already been part of these clinical trials, they've now been in these trials for much longer than 8 weeks. And so if there were going to be any significant adverse reactions, we would have picked it up by now. So that's one additional piece as well about the COVID vaccines. All right, let's go to the next one. Can I get the COVID vaccine if I have diabetes, heart disease, sickle cell, lupus, or sarcoidosis? Dr. Norris, what's your answer to this?
Yes, you should. So if you have those conditions, you are much more likely, and you get the COVID infection, you are much more likely to be hospitalized or die. And there does not appear to be any additional risk of worsening any of these conditions if you get the vaccine. So it's not the type of vaccine, it's not like an attenuated vaccine where you can, some other vaccines we do have, if your immune system is not up to speed, then you can actually develop the condition. That doesn't happen here. So if you have those conditions, that's all the more reason to be signing up to get your vaccine.
Great, thank you. Dr. Harara, what about this one? We've heard this before. I don't trust the vaccine since it was made by the government. They just want to experiment on Black people. Can you address this concern?
I'll do my best. I think it's important to realize that there's multiple vaccines and they were made not by one entity. The US government, NIH, had a role in the technology that went into the mRNA technology for the vaccines, and particularly the Moderna vaccine. But that's just one of the vaccines, and that was just one component of the scientific teams that made the vaccines. There's huge numbers of people and players in making these vaccines. There's multiple companies that have been contracted with the US government to develop the vaccine. And the question talks about concerns about experimenting on Black people, but the vaccines have been tested on people of all different backgrounds. Just about, as Dr. Norris said, just about 10% of the participants were Black, and they're being rolled out for people of all different backgrounds. So I guess I would, there's kind of two answers. Obviously, the vaccine wasn't just made for us, or it's not just being tested on us. And two, the government was just one player in the development of the vaccines and the science behind the vaccines. And I'll just add that even though Pfizer, BioNTech, which is kind of two companies that work together on one of the vaccines, and then Moderna are just two of the companies that have been contracted in the US for vaccine development and production, there are actually 4 others. And there's also, and BioNTech is actually a German company, not even a US-based company.
Great, thank you so much. Dr. Mays, we've heard this one as well. I am healthy and I wear a mask. Why do I need the vaccine? Oh, you're on mute. There you go.
Okay. It's very important for people to think about this concept of you can have something and not look like you're sick. So we often try and tell people that you may think you're healthy, you might actually be healthy. There's 2 reasons to wear this mask. One is to protect yourself, and the other is to protect other people. One of the things I try and tell everybody, we're all in this together. You may be healthy, but you may be, asymptomatic, but the person that walks along the sidewalk next to you, they just might not be as healthy. The other reason for you to wear the mask if you are healthy is so that you stay healthy. One of the things is we started out with the myth that it was only older people. And what we're starting to see is that, there are younger people who have underlying conditions that sometimes they are aware of and sometimes they're not. So it's just very important to wear the mask because you're a part of a society where we're only going to get this under control if we're all behaviorally doing what we're asked, which is wear masks, frequent hand washing. That's very important as well. And also to physically distance.
Great, absolutely. Thank you so much. And our last concern that we've heard very commonly is, I'd rather wait and see what happens to other people first before I get this vaccine. So Ms. Luke is right. Are you able to address this additional concern?
Yes, I can. Thank you. Well, at least we're hearing that folk are saying that they want to wait, because I can remember a time when you asked about it. The preponderance of the responses was, in the immortal words of Whitney Houston, "Hail to the no." But so folk are now saying, "I'd rather wait." But this is the issue. This self-assignment is tantamount to Black folk assigning themselves to the back of the bus, or people of color assigning themselves to the back of the bus. So we know some things. We know that the preponderance of these medications are well over. Of these vaccines are showing success in over 94 or so % of the time. So we know that to be true, but we also know that the virus is killing people. And so I think that when we weigh those 2 things, when we sort of reason together here, then we need to understand that we don't have time to wait. It's a public health issue if we wait, because that means you have more opportunity to contract it and or pass it on. And so the waiting is not good. The waiting does us absolutely no good. And something tells me that if we ran an ad in the paper that said all people of color have to wait until we see how this is going to work. You all have to wait. You'll get your vaccine later. I have a feeling folk would be very upset about that. So I think that we need to just really move away from the wait. And in fact, it's interesting that I had that particular question assigned to me because our second Sabbath Town Hall was entitled The Cost of Waiting. And we took quite a look at what that might look like.
Wonderful. And that is so incredibly important. We have to make sure we're not preventing ourselves from actually receiving various different treatments and preventative measures to keep us healthy and our communities healthy. That's very important piece. So thank you all. So our Q&A section is blowing up. So what I'm going to do, panelists, I know we have one last question I was going to ask you about some of your recommendations. But what we'll try to do is at least get to some of the questions and we'll see if we can end on your recommendations to continue to build trust. Is that okay? All right, we're going to jump on in. So thank you all, everyone, for those of you all that did place a question in here as well. And so what we're going to do is start with the question that it has the most number of votes. So the first question was, since we know that COVID is specifically harming minority groups and communities, how is it we have all the his systems wound up rolling out a vaccine plan that doesn't take those facts into considerations? Nothing I have seen says any health system is reaching out in a way to make sure these communities are taken care of. And I don't just mean education and trying to convince us the vaccine is safe, but actually showing up with the shots. What are we going to do right now to prioritize the groups that are more likely to die from the virus we are fighting? So I'm going to take a first shot, and then I'm going to open it up to the rest of the panel. In terms of this question, this is a very important question that the anonymous writer wrote. And the reason why is because our vaccine distribution process, it's not just based locally. It's coming from the federal government, it goes to the state, it then goes to the county, and then it's distributed. And so in terms of the availability of vaccines, it's a much larger process than just the control of a specific clinic or a specific institution. So that's something to really be aware of. And there's certain phases that have been recommended. And again, it all comes down to the overall national and state distribution. But what we can talk about is at least what we've been doing on a local level. And I can specifically speak about UCLA Health in terms of our vaccine distribution process. We absolutely took into account the social vulnerability of all of our different communities, so both our employees as well as soon to be our patients as well. And so one of the things that we took into account, three different factors: your overall occupational risk, your overall individual clinical risk, and yes, your social vulnerability. And one of the ways that we did that is really thinking about a risk score that includes the social vulnerability of where a person lives. And that includes, for instance, your based off of the housing density in your environment, based off of who lives in your community, food insecurity, all of those factors that Dr. Mays mentioned in terms of those social determinants of health that we know are directly linked to actually getting the COVID vaccine, being hospitalized and dying. We incorporated that so that when we distribute this vaccine, it is done in a very fair and equitable way to get to the people that need the vaccine first. So at least that is something that we as UCLA Health have actually already implemented, and using a lot of the data from the social vulnerability indices, and also Dr. Mays, as she mentioned, her team have created these amazing vulnerability indices as well in order to ensure that vaccines get to the right populations and the right individuals as soon as possible. But we all still have to, it's a coordinated factor across the country. Any other input for that one?
I think I'll make a couple of comments. One of the things that's happening with LA County, because I'm also working, they're also using our models, so we're also working with LA County, is because the vaccines require refrigeration in the way that they do. It's part of that. There's actually a team that is looking at where is the place to go in the community. We need a certain amount of space. You know, we need to figure out a way in which to be able to do that distribution. The other thing that was an issue is some of the community health centers that are actually community health centers, what we call lookalikes, not necessarily designated as a federally qualified health centers, they were left off the list. So it took a little longer. So LA has, one of the things about California is that we have a very robust health system. And so they didn't quite get it right at the feds in terms of the way in which we label some of our systems. So that also led to a delay. So there are a lot of things that are all in play at one time. And I don't have to tell you, there have been politics that have slowed it down somewhat. But there is actually a focus on using these vulnerability models to make sure that what's being rolled out is rolled out with people who need it the most because of that vulnerability, not the privilege, but the vulnerability.
Great. Thank you so much as well, Dr. Mays. We're going to go to the next question, and we have the person who's asking the question here with us. Would you like to go ahead and ask the question? And this will be and Thomas, tell us how you pronounce your last name as well.
Yes, hello.
Hi,
Um,
welcome.
Hi. So I just thank you so much for convening the talk. I really appreciated all the insight that you all were able to provide. So I know a lot of us have been dealing with, the fallout from a lot of the racial injustice in the United States over the last 6 months. And one of the questions I had was, action at a federal, state, and local level is needed, but at an institutional level, what is UCLA doing to help out?
Great question. I will go ahead and start a little bit on that one as well and ask my colleagues. So UCLA in general has a true focus also on advancing health equity, as well as just overall equity, diversity, inclusion throughout the campus. Specifically within the UCLA health system right now, we have a strategy which involves various different levels, including data analytics, developing interventions to ensure that we have equity between our patient populations, and expansion of access to care to our most vulnerable populations that need our help. And so part of this is that there is a reinvigorated recommitment to advancing health equity and making sure that we're playing our part locally as well. So if anybody is very interested, you can always go to uclahealth.org/HEDI, which stands for Health Equity, Diversity, Inclusion. In addition, there's many efforts that are going on within our School of Medicine, as well as in our School of Public Health, in order to ensure that we have the education, we're training, and then we're also doing the research in order to develop the best interventions possible to continue to promote equity throughout our communities, not only here in Los Angeles, but nationwide. So anyone else from the panel like to comment on some of our efforts right now with UCLA?
Sure, I'll go ahead.
Great.
So thanks, Dr. Briggs-Melanson. And I'll save some time for Dr. Mays, because she's been doing a lot of work, and Dr. Rara as well. At an institutional level, the first thing the institution has had to do, as you said, when all these episodes were occurring, was to take a look at itself, right? And recognize it's not where it needs to be. And so there were a lot of hard conversations that were occurring with faculty, with staff, with students, and that's led to a reassessment and an increase in the level of acuity and effort for some of the activities that you just heard, and to really think about what needs to happen, right? So first, you have to make sure you're taking care of your own people, right? So we have to take a look at our staff and make sure our staff are being treated, that there's equity in treatment of the staff, and hiring and retention. Students are treated appropriately, faculty are treated appropriately, our patients are treated appropriately, to make sure that patients are getting the type of care that they should be getting with the level of respect and the level of attention that they deserve. And so that's the first thing, and I think that's where we're focusing on as an institution. And then from there, we will be in a better position and a better place to leverage the brand per se of UCLA to have a similar impact on the rest of many other institutions in Los Angeles. But I think it's important that we have to look internally and make sure we have everything operating appropriately internally before we can really go out and start doing things externally, except for those, the patients and people within the UCLA health system. But I think to have the impact we'd like to have, we really need to make sure we're doing the right thing ourselves.
I'll also comment here because what people may not realize the extent to which UCLA faculty, particularly in the health system, as well as those of us who are doing research, have been involved on a national level of making sure that the policies and practices have health equity in them. So for example, there is a member of the UCLA Health that is actually on ACIP, that was the big committee that made the decision about 1A, B, and C. And that person, I actually talked to that person. That person had equity in mind when they came to the table. And what I thought Dr. Norris was actually going to talk about was also the funding that his group received from NIH to actually at a state level coordinate not just the UCs, but to coordinate the UCs and be better collaborators with the community. If you think about, again, policies and practices, I actually worked with the Congressional Black Caucus. Many of you heard very early on that we were not getting data on race and ethnicity. I happen to be appointed by Nancy Pelosi that sits on the federal government's committee on data. And so I helped to write the piece that was actually in the CARES Act that required the federal government to do better on its data collection. So we have these day jobs, many UCLA people do, and we work our day jobs, but we also are giving the very knowledge that we learned first here to outside agencies because we need those policies and practices to represent what we know from being on the ground. So I would say UCLA has actually given a lot of sweat equity in terms of making sure that we're pushing for, racial ethnic equity.
Thank you for that, Dr. May. That sort of reminded me because Dr. Briggs Melanson is leading the physician cohort of a bill that has been introduced in Congress, a racial health equity bill. And so, as again, some of the things that we're trying to do above and beyond our day jobs.
Yes, and thank you, Dr. Norris, for that. We all forget what we do outside of our day jobs, all the important work we all do. So we always have to remind each other that, again, amazing panel. It's always a pleasure to be with you all. We're going to keep on going right on through our next question, and we have Nadine that's actually here with us. And Nadine, I think we may have missed her, but we will promote you back in just a moment. There is one additional question from an anonymous writer. What are the effects of the vaccine for a pregnant woman or one planning to become pregnant? I will direct that. Who would like to answer that?
Yes, that's me.
Okay, is that you? Okay.
So as of now, there's no known adverse effects. It is recommended that it can be used. And so that's the status right now. There's that it similar to individuals who have other medical conditions, although pregnancy is not a disease, but there's more things going on in the body than normal. It is recommended that vaccines should and could be offered to individuals who are pregnant or thinking of becoming pregnant.
Great, thank you.
Now I just have a couple of additions to that, because I think about this a lot and I've been asked this question a lot. One addition to that is COVID-19 is very dangerous for pregnant women. COVID-19 as a disease is also very dangerous for women who are delivering babies. And so in that setting, in this risk-benefit analysis, I think that's important. The other piece is we don't know when a vaccine is going to be available for children, and we don't know when it's going to be available for babies, if at all. But maternal transfer of antibodies, so that protective immunity in the mother actually can transfer to the baby and protect the baby from COVID-19 as well. So just to make those 2 points as well.
Thank you.
Thank you so much. So once again, the nutshell of it is, yes, the vaccine is very important. Please speak to your doctors if you have any additional questions, but we highly recommend it for both yourself as well as the baby. Now, this next question is incredibly important, and I would like to make sure, especially that Dr. Herrera answers this first, and then we'll see from the other panelists as well as Ms. Lucas, right? Because I think these are really key questions from your two perspectives. The question is, could you expand on the role of a non-BIPOC or Black, Indigenous, person of color, physician, psychiatrist, etc., in terms of combating medical racism and racial health disparities on an individual basis? So I would like to have Dr. Herrera start, and then Ms. Lucas, right, you can add some additional perspectives of how a non-BIPOC provider can ensure to combat medical racism and racial disparities.
Yeah, I really appreciate this question. I think it's really important for everybody to understand that they have a role. And one of the things that I've appreciated about the dialogue that's occurred since George Floyd is increased dialogue around not just wanting to be not racist, but anti-racist. And there are a lot of tools that really speak actively about how it is that people can engage and understand both their potential implicit bias that they might have. We all grew up in a society that has racism, sexism, homophobia, so none of us are immune from absorbing some of those messages. And so I think it's part of that involves personal reflection. Another piece of it does involve understanding the history of how it is that racism has manifested in the medical enterprise, and I mentioned just a few of those things. And then another piece really is looking at your own institutional setting, whether it is that you're in a small practice or a larger setting, and seeing ways in which there may be inequities in which treatment is occurring, and then being active about trying to address that so that you create a more welcoming and equitable environment for people to come in. And I'll just give one basic example. And this is an example that an African-American provider gave, but it was about another racial and ethnic group. So she worked as serving pregnant women in a setting that was predominantly immigrant Latino women. And in this particular setting, they wouldn't give people appointments. They would literally tell people, show up at the beginning of the day if you want to be seen by your provider, and we'll serve you whenever it is that we have time to get around to you. And so she advocated, like, these women's time is just as valuable as anybody else's time. We might, for whatever reason, we might somehow think that it's not, but this is not an appropriate way for you to be treating your patients. But there's, I mean, that's a somewhat egregious example, but there's plenty in multiple institutional settings. So I think it's really important that we look internally, we understand what's going on within our setting, and then we really also keep in mind that history, so that when we have patients who come in and are extremely guarded, that providers aren't then creating a bigger gap because they feel uncomfortable and the patient feels uncomfortable. Instead, they're able to sit in non-judgment, be able to get that patient to open up, and hopefully then start that process of building trust.
That's wonderful. So seeing that person for who they are, understanding, and just really spending that time with them. Thank you. Ms. Luke is right. Oh, just one moment, you're on mute, so just let us unmute you. Just,
I know you're going to have some more wisdom to share on this.
I know, so
Okay,
there we go. All right.
Okay, thank you. I was saying that Dr. Herrera did an amazing job of covering this. I would just say that it really, and this also is true. This also is true. My birthday is next week, and so I'm just full of wisdom. But it really is true that people don't care what you know till they know that you care. That really is true. My favorite doctor, I liked her because whenever I came in, she would turn her chair and face me and lean into me and talk to me. And that meant so much to me because I don't care if she was pretending, I bought it because she did everything she needed to do to let me know that it's not necessarily what's on that screen. I want to look at you. I want to know how you feel. I want to know what's going on in your life. And it just mattered. And I told her far more things than I probably would have ever told anybody else. So if you really want to get all the information to help you move the needle on good outcomes, try to act like you care about your patients. And when you have a patient that is of a different race and ethnicity, find out about whether or not that medication is good for them. When I just got prescribed yet another medication, that's what happens when you get old. I got prescribed another medication, and so I asked her. I said, "Well, how do Black women do with it?" So I really wanted her ahead of time to know this kind of thing, and so so find out. Ask, turn the page, get another book, find out about the specificities and sort of the individualized kind of information that you need to have for your patients. Uh, I know that the U.S. Health Task Force is always sort of giving these recommendations about when certain kinds of screenings ought to happen. Well, find out if in the Black community, in the Latino community, the Pacific Island community, find out if in fact that holds true for that community. There are so many cancers that we were getting a whole lot earlier than age 50. I did I did a research project in the faith community, and it was based upon the U.S. Health Task Force recommendation of age 50. Well, that did not work so well because there were so many people. Every church had folk who had a litany of names of people who who developed cancer much earlier and died by the time they got to 50. So you just really need to. You just have to be take the time to do a little bit more work and find out again, have an individualized approach to those that you are treating, and I think I'll stop there.
No, but that's incredibly important. And the fact that you just said, treat your patients with care. Okay, like that's huge. That's really the core of it. And so we're almost around time. So I'm gonna just ask one last question and then we're just gonna wrap up with some final thoughts. We know that we were not able to get to all of your questions, but we can tell you there will be some additional discussions for patients and other non-medical staff. We've had them. We will continue to do them, and we'll talk to you about that. And then several of the other questions that are here, we will give you more information if you do have some additional questions where we can answer them. So the last question, and then I wanted to turn it back to the panelists for their final thoughts. Is Bell's palsy a side effect? If yes, which one of the vaccines is associated with Bell's palsy? So Dr. Norris, I'm going to just go ahead and punt this on over to you, and so you can answer that one.
So it's not really known. I think there have been one or two people in the trials who have developed Bell's palsy, but Bell's palsy occurs in the general population anyway at a certain rate, right? And so we don't, right now, it doesn't appear that it's happening any more frequently than it happens in the general population. But we can't say absolutely that it's not. But it does, but at least right now, it doesn't appear to be any more common than the general population. So you have to think, whenever people are in these, you have 37,000 people in these clinical trials going on for months, like life happens to them too. Just because they're in the trial, like all the other diseases or problems you can get don't stop and say, oh, you're in a trial, I'm not going to happen to you. So all those things can keep happening and do keep happening. And so That's what we know about Bell's palsy. Clearly, that stands out more than having some headaches or aches and pains for a couple of days. That's clearly something. But usually, again, like Bell's palsy in the general population, it's self-limited and goes away after a couple of weeks.
Great. Thank you so much, Dr. Norris. And so this has been an absolutely wonderful panel. I know I've thoroughly enjoyed myself in being with you all. And I just want to close it with a one or two thoughts, very short, very brief, on what each one of you all thinks is the most important thing that we as a healthcare community, as the Black community, as just the community of people in love, what is the one thing that we need to do to start to rebuild medical trust within the Black community and other communities of color? And I'm going to start off with Dr. Harara.
The one thing, I think all of our institutions need to hire and up-level the voices of people like ourselves, the members of the communities who know those communities and can speak to the particular needs of the communities in a way that maybe other individuals can't. I think there are so many other things that I got to address this on the last question, so I'm going to turn this back over to the other panelists.
Great. Dr. Mays.
I'm actually going to talk about, for this question, almost what Nina was saying, but we need more of you. You, for example, are an individual that has been given the mantle of diversity, equity, and inclusion. And as Nina says, it's the concept, and you actually use this phrase, of lead and serve. I think if we are put in the positions to be able to do that, like I'm the special advisor to the Chancellor for Black Life, you're doing that, you can begin to see the transformation that's happening. We are in the community, we are of the community. Many of us haven't forgotten our roots in the community. So I really agree with what Dr. Harara said, is that lead and serve, but with us.
Love it all.
And
Dr. Norris, go ahead.
I'll just add, I agree with that absolutely, and so that's very important. Lead and serve, and then we want everybody in this together. And to be in it together, you need to be alive, right? So we want you to think about taking the vaccine today, so you can be here to fight mistrust and mistreatment with us tomorrow.
That's right. And let's go with Dr. Garner.
For me, in building trust, in the medical trust of the Black community, it's about mentoring. So if you find yourself as a Black medical professional, reach out to your community, mentor youth, be there for youth, whether it's high school age, college age, in the medical training. That individual mentoring is really what's going to build our overall numbers that really allow us to address and fix some of the institutional challenges that we see in the medical community. Because until those challenges are fixed, or until they're actively being addressed, we haven't earned the trust of the Black community. And so this is work we have to do.
Absolutely. And Ms. Luke is right. Last but definitely not least.
Thank you. Absolutely. Try to be as transparent and honest as you can. Serve with humility, and remember that your patient is a living soul and worthy of respect. Treat them like, and I think we all learned this when we were little: do unto others as you would have them do unto you. Very simple. And I think the final thing would be, I will certainly intone the Bible. To whom much is given, much is required.
Thank you. And of course, I have to include one item too. And what I would say is serve with courage and lead with courage. And what that means is that I think that is really important for those of us within the healthcare field, no matter what professional role that we play, that we address each person as the individual they are. We address their needs as if they are our family, because they are our family. And then also those that are us in the community, just knowing that it's a new time. Find the doctors, the nurses, the other clinics that you feel comfortable with, and make sure that you're not holding yourself back from having the healthiest life possible. And so on those notes, we're going to start and close. And couple of closing thoughts. Number one, I just want to thank our panelists, our performance excellence logistics team, health IT team, communications and marketing teams for doing so much behind the scenes. And I want to thank each and every single one of you all. We had over 500 people that actually joined this symposium. This is our very first symposium. So we hope that you're going to go away with open minds and open hearts in order to be the change agents that you are. Now, one key thing before you leave, we don't want to leave you without any type of call to action. So we do have something for you. We are actually planning a day of service. And I'm going to have Dr. Mays mention this, and I couldn't get the Zoom link up there, but I'm going to tell them how they can still make sure to join that Zoom. Dr. Mays.
Exactly. As you know, it is MLK weekend coming up. We're going to ask you if you will talk to 3 people in your network, share with them the information about the vaccine, find out their questions, try and answer their questions. And on Monday at 3 p.m. for that one point in time, the UCLA health system is pulling together both its physicians and scientists to be available to answer questions. So share, as they say, each one. So please do that. 3 people, if you can spread this knowledge, and we will be there on Monday as a day of service.
Thank you so much, Dr. Mays. And so if you want to participate in the day of service, meaning bring your family members, bring your friends, whomever it may be, please email equity@mednet.ucla.edu, and we'll make sure that you get that Zoom link, and it's open to the public. Email equity@mednet.ucla.edu, as you can see. We also have some additional resources for you. If you want any additional information, you can actually go directly to uclahealth.org COVID/19/facts, as well as there's also the Bright Center email address that is there. And I'm going to include one additional item for you all to also make sure to go to. And this is also our center here. And this is Dr. Harara's center as well, in which you can dive deeply into all the information in her center about COVID also. So once again, we have several different resources for you all. We are always here for you as UCLA Health to answer any questions that you may have. And on that note, I would like to say once again, thank you so much for visiting us. Thank you for joining and spending time with us. Continue to take care of yourself, each other, and the community. Have a good night, everyone. Be well.